Welcome to the deep dive. Today, our sources guide us into a really crucial area, the kidneys, and specifically what happens when they start to fail, either suddenly or over a long period.
Yes, we're looking at renal failure. Basically, that's when the kidneys lose their ability to clear out metabolic waste products and they can't regulate the body's fluid, electrolytes, or pH balance anymore. It's a major breakdown.
And it seems this failure generally shows up in two main ways, two quite different disorders.
Exactly. You've got acute kidney injury, AKI, on one hand. That comes on fast, like hours to days, and crucially, it's often reversible if you catch and treat the cause early.
Okay, fast and potentially fixable. What's the other side?
That's chronic kidney disease, CKD. This is the slow burn. It develops over months, even years, and represents permanent, irreparable damage to the kidney structure.
And this is where that really striking fact comes in, right? About how much function needs to be lost before you even know there's a problem.
It's quite incredible. You need to lose function in about 80% of the nephrons. Those are the tiny filtering units before the clear clinical signs of CKD start appearing.
Wow, 80%. That's a huge amount of hidden damage.
It is. The body compensates remarkably well, but it means the disease is very advanced by the time it's obvious.
Okay, so for this deep dive, our plan is to really map this out. We'll look at the different types of AKI first, then move into CKD, how it progresses, and how it affects, well, pretty much the entire body.
That's the plan. We'll cover the causes, the mechanisms, and the system-wide consequences.
All right, let's start with AKI, the acute one. The sources define it as a rapid decline, a sudden hit to kidney function. What's the immediate consequence we see?
Well, the most common indicator is something called azotemia. It sounds technical, but it just means nitrogenous wastes. Things like urea, nitrogen, uric acid, creatinine start piling up in the blood because the kidneys aren't filtering them out.
And that goes hand in hand with a drop in the filtration rate, the GFR.
Exactly. Azotemia and a decreased GFR are the key signs of that rapid decline in function. And importantly, this whole process throws fluid and electrolyte balance way off kilter.
Now, you mentioned AKI isn't just one thing. It's categorized based on where the problem starts. Could you walk us through those three locations? Prerenal, interrenal, postrenal.
Absolutely. Think of it like plumbing. Is the problem before the filter, inside the filter, or after the filter?
Okay, simple analogy. Let's start before the filter, prerenal.
Prerenal AKI is the most common type. The issue here is before the kidney itself specifically, there's not enough blood flow getting to the kidneys.
So what causes that lack of blood flow?
It could be serious volume depletion, from a major hemorrhage, severe dehydration, like from vomiting or diarrhea, or extensive burns, losing lots of fluid.
Or maybe the pump itself is failing.
Right. Impaired perfusion, the heart just isn't pumping effectively, like in heart failure or cardiogenic shock, or even decreased vascular filling, think anaphylaxis or sepsis, where the blood vessels dilate too much. The kidneys are essentially being starved of blood.
And we really need to highlight the drug risk here too, don't we? Even common ones.
Oh, absolutely. Certain drugs can tip someone over the edge,
Yeah.
especially if their kidney perfusion is already borderline. Things like vasoactive drugs, obviously, but also radiocontrast agents used in imaging.
And the big ones people might not realize, NSAIDs, ibuprofen, naproxen, and even very common blood pressure meds like ACE inhibitors and ARBs.
Yes, in someone who's dehydrated or has underlying heart failure, these drugs can precipitate prerenal AKI by interfering with the kidney's own mechanisms for maintaining blood flow.
So if you suspect prerenal AKI, what's the key lab finding? You mentioned a ratio.
Yes, the BUN to serum creatinine ratio. Normally it's around 10 to 1. In prerenal AKI, because the kidney is desperately trying to hold on to water, it reabsorbs more urea along with that water. Creatinine, however, isn't reabsorbed as readily.
So the BUN level in the blood goes up disproportionately.
Exactly. That ratio jumps up, often above 15 to 1, sometimes even 20 to 1. It's a strong indicator that the problem is reduced blood flow to the kidney, not damage within it yet. And you'll also see a sharp drop in urine output.
Okay, that makes sense. So that's the before the filter problem. What about interrenal AKI, damage inside the kidney?
Right. Now, the injury is to the actual structures within the kidney, the glomeruli, the filters themselves, the tubules, the processing tubes, or the kidney's blood vessels.
And what usually causes this direct damage?
A major cause is actually prolonged ischemia. If that prerenal state, the lack of blood flow, isn't corrected quickly enough, it eventually damages the kidney tissue itself.
So prerenal can actually turn into interrenal AKI.
Precisely. Other big causes are direct toxic insults, certain drugs, heavy metals, solvents, or intertubular obstruction, where something blocks the tubules from the inside.
Let's focus on the most common type of interrenal damage, Acute tubular injury or necrosis, ATN. Can you sort of paint a picture of what's happening inside those tiny kidney tubes?
Okay, imagine the epithelial cells that line these tubules. When they're starved of oxygen, ischemia, or exposed to toxins, they get injured and start to die and slough off.
Like shedding their lining.
Kind of, yeah. These dead cells and debris then clump together and physically block the tubule. This blockage increases the pressure upstream, which stops filtration and so it's plummet. It basically causes the GFR to plummet.
And there's another problem too, something about leakage.
Yes, because the tubular wall is damaged, the filtrate fluid that should become urine actually leaks back out of the tubule into the surrounding kidney tissue, the interstitium. So less urine is made, and what is made can't get out easily.
You mentioned intratubular obstruction. What kind of things can block the tubules from the inside?
Well, for example, in hemolytic crises where lots of red blood cells break down, hemoglobin can clog the tubules. Or in cases of severe muscle injury like crush injuries or even extreme overexertion, myoglobin is released.
Right, that's myoglobinuria. That can make the urine look really dark, can it?
Yes, it can turn the urine tea-colored, red, brown, or sometimes even black. And finding specific things in the urine under a microscope, like dirty, brown, granular casts, is a classic sign pointing towards that acute tubular injury, ATN.
Okay, so we've covered before and inside. The last category is postrenal AKI, problems after the filter.
This one is usually simpler conceptually. It's an obstruction of urine outflow somewhere after the kidney and the ureters, the bladder, or the urethra.
So like kidney stones.
Kidney stones, yes. Or strictures, which are narrowings in the ureter, tumors pressing on the urinary tract. Even problems with the bladder itself, like neurogenic bladder, where the nerves don't work right.
And a really common one, especially in older men.
Prostatic hyperplasia and a large prostate gland is probably the most frequent cause of postrenal AKI because it obstructs the urethra.
How does the blockage cause kidney injury?
It causes urine to back up. This leads to increased pressure within the collecting system and the tubules, eventually causing damage to the nephrons from that retrograde pressure.
But the good news here is,
The good news is that if you can identify and relieve the obstruction, remove the stone, shrink the prostate, bypass the tumor, you can often restore kidney function, especially if caught early.
now, regardless of which of these three types starts the AKI, our sources say the injury itself tends to unfold in a sequence of phases. Can you outline those?
Yeah, it's a fairly predictable pattern. First is the onset phase. This is just the period from the initial insult, like the hemorrhage or the toxin exposure, until the actual kidney injury occurs. It can be hours or days.
Then what happens?
Then you hit the oliguric, or sometimes the neuric phase. Oliguric means low urine output, and neuric means basically none. This typically lasts about 8 to 14 days, though it can vary.
And this is the really critical time.
Absolutely. The GFR drops dramatically, urine output plummets, and you get this sudden retention of all those metabolic wastes, urea, potassium, creatinine. Fluid overload and edema become big problems. You might start seeing early signs of uremia, like confusion or even seizures.
Okay, that sounds bad. What comes after the oliguric phase?
Next is the diuretic phase. This is when the kidneys start trying to heal and recover. Urine output actually increases, sometimes quite a lot.
Wait, more urine output sounds good. Isn't that a sign things are getting better?
It sounds good, but it's deceptive. While the kidneys are putting out more fluid, the tubules are often still damaged and scarred. They can't concentrate the urine properly or manage electrolytes effectively yet.
Ah, so even though there's lots of urine, the quality of kidney function isn't back.
Exactly. The BUN and creatinine levels might still be high or even continue to rise initially. And importantly, the patient is at high risk for losing too much fluid and electrolytes, leading to dehydration and imbalances like low potassium. It's a fragile period.
Okay, so diuretic phase isn't necessarily safe phase. What's the final step?
The recovery phase. This can take a long time, sometimes up to a year. Tubular function gradually improves, the edema resolves, and the GFR slowly climbs back, hopefully towards normal, maybe settling around 70–80% of what it was before the injury. Full recovery isn't always guaranteed.
All right, let's shift gears now from that acute, potentially reversible AKI to the other major category. Chronic kidney disease, or CKD. This is the slow, progressive, permanent loss of function. How is it formally defined?
CKD is defined either by evidence of actual kidney damage, like abnormalities in blood tests, urine tests, or imaging, or, crucially, by having a glomerular filtration rate, GFR, less than 60 millimole per 1.73 square meters of body surface area that persists for 3 months or longer.
Less than 60 for 3 months. And what are the main drivers behind CKD, especially here in the U.S.?
Overwhelmingly, the two leading causes are diabetes and hypertension. Poorly controlled blood sugar and high blood pressure over years just relentlessly damage the delicate filtering structures in the kidneys.
We measure kidney function mainly by GFR, right? What's considered normal?
Yeah, GFR is the best overall indicator. Normal GFR is typically around 120 to 1 in 30 millimin, 1.73 meters Ross. So you can see a GFR below 60 represents a significant loss of function, less than half of normal.
You mentioned GFR might not be the earliest sign, especially in diabetes.
That's right. Before the GFR starts to drop noticeably, we often see protein leaking into the urine, specifically small amounts of albumin, called microalbuminuria.
And how do we measure that?
We use the urine albumin to creatinine ratio, or UACR. A value between 30 and 300 milligrams of albumin per gram of creatinine is considered microalbuminuria. Detecting this early is critical, particularly in diabetics, because it signals kidney damage is starting, even if the GFR looks okay.
And again, that incredible compensation kicks in, hiding the problem.
Exactly. Symptoms usually don't become apparent until the disease is very far advanced, often when that GFR is already quite low, because the remaining healthy nephrons work overtime, they hypertrophy to pick up the slack.
But eventually, that compensation fails. And this is where, as you said, it gets really interesting because the failing kidney impacts literally everything else.
It really does. The pathophysiology extends far beyond just the kidney.
Once waste products build up significantly, we enter a state called uremia.
Which literally means urine in the blood. What does that look like symptomatically? Early on, it's often subtle, non-specific things, weakness, fatigue, maybe some nausea, loss of appetite. But as uremia worsens, it affects almost every organ system. Eventually, you see more severe neurological symptoms like lethargy, confusion, difficulty concentrating, and if untreated, it progresses to seizures, coma, and death.
Let's break down some of those systemic effects. What about fluid, electrolytes, and acid-base balance?
Well, fluid balance can go either way. Early in CKD, the kidneys might lose their ability to concentrate urine, leading to polyuria, frequent urination, and risk of dehydration. Later on, as GFR plummets, they can't excrete enough fluid, leading to overload, edema, and hypertension.
And electrolytes. Potassium is always a big concern with kidney failure.
Yes, hyperkalemia, hypotassium becomes a major risk, but usually only when the GFR drops really low, like below 5 or 10 millimillimin. Before that, the remaining nephrons can often compensate.
What about acid base? You mentioned acidosis with AKI too.
Same problem in CKD, but developing slowly. It's metabolic acidosis. The kidneys progressively lose their ability to excrete the daily load of metabolic acids, hydrogen ions, and also fail to regenerate bicarbonate, which is the body's main buffer.
And where does the body turn for buffering when bicarbonate runs low?
It turns to the bones. The skeleton has a huge buffer reserve, releasing calcium carbonate to neutralize the acid, but this comes at a terrible cost to bone health.
Which leads us directly into CKD mineral and bone disorder, or CKD-MBD, sometimes called renal osteodystrophy. This seems really complex. Can you break down the mechanism?
It is complex, involving vitamin D, calcium, phosphorus, and parathyroid hormone, PTH. Okay, so first, the failing kidney can't perform the final step in activating vitamin D. You need active vitamin D, calcitriol, to absorb calcium from your gut.
So low active vitamin D means low calcium absorption.
Right. Low calcium in the blood. At the same time, the failing kidney also can't get rid of phosphate effectively, so phosphate levels in the blood start to rise.
Okay, low calcium, high phosphate. How does the body respond?
The parathyroid glands sense the low calcium and the high phosphate, and they go into overdrive, pumping out massive amounts of parathyroid hormone, PTH. This is called secondary hyperparathyroidism.
And what does all that extra PTH do?
PTH tries to raise blood calcium by stimulating the bones to release calcium. It also tells the remaining functional kidney tubules to reabsorb more calcium and excrete more phosphate. But in advanced CKD, the kidneys can't respond well, and the main effect is just relentless bone breakdown.
So this leads to actual bone disease. You mentioned 2 types.
Yes. You can get high turnover bone disease like osteitis fibrosis cystica, where there's excessive bone resorption driven by the high PTH, or sometimes you get low turnover bone disease like osteomalacia, soft bones, or adynamic bone disease where bone formation itself is suppressed. This can sometimes happen if PTH is oversuppressed by treatment or due to factors like aluminum toxicity in the past.
Okay, that's the bone connection. What about the blood? You said anemia is a major issue.
Anemia is probably the most profound hematologic change in CKD. We typically define it as hemoglobin below 13 GDL in men, or below 12 GDL in women.
And why does kidney failure cause anemia?
The main reason is that the kidneys are the primary producers of erythropoietin, EPO, the hormone that signals the bone marrow to make red blood cells. As the kidneys fail, EPO production drops, and red cell production slows down.
Are there other factors contributing to the anemia?
Yes, the uremic environment itself can suppress bone marrow function somewhat. Chronic inflammation plays a role, and patients with CKD often have increased blood loss, maybe from dialysis or just impaired platelet function, leading to easier bleeding.
And this anemia isn't just about feeling tired, is it? It puts a strain on the heart.
A huge strain. The heart has to pump harder and faster to deliver enough oxygen to the tissues when there aren't enough red blood cells. This increased cardiac output contributes significantly to cardiovascular complications.
Which brings us to the cardiovascular system, often the biggest killer in CKD patients.
Absolutely. Cardiovascular disease is the leading cause of death. Hypertension is almost universal in CKD.
Why is blood pressure so hard to control?
It's multifactorial. Fluid overload is a big part of it. But also, the failing kidneys often inappropriately activate the renin-angiotensin system, which constricts blood vessels and drives up pressure.
So treating the hypertension aggressively is key.
Essential. Using drugs like ACE inhibitors or ARBs is particularly important because they not only lower blood pressure but can also help slow the progression of the kidney disease itself, especially if there's protein in the urine.
What other heart problems are common?
Heart disease is rampant. Left ventricular hypertrophy, LVH, where the main pumping chamber gets enlarged and thickened from working against high pressure and volume, is very common. Ischemic heart disease, coronary artery disease, is also prevalent. The anemia and fluid overload constantly stress the heart.
And in very late stages.
You can get uremic pericarditis, which is inflammation of the sacs surrounding the heart caused by the buildup of uremic toxins. That's a serious complication, often requiring urgent dialysis.
Okay, we've covered waste buildup, fluids, bones, blood, heart. What about nerves and other systems like skin?
Uremia affects the nervous system too. Peripheral neuropathy is common, causing symptoms like numbness, tingling, burning feet, or restless legs syndrome.
And the brain.
Uremic encephalopathy reflects the effect on the central nervous system. It ranges from subtle things like reduced alertness, poor concentration, and memory loss, to more severe confusion, drowsiness, and eventually coma. A classic physical sign is asterixis, sometimes called a liver flap, but seen in uremia too. It's an involuntary flapping tremor, usually of the hands when the wrists are extended.
And the skin. Patients often look pale, right?
Pale, yes, partly from the anemia. The skin also tends to become dry and flaky, a condition called xerosis. And one of the most distressing symptoms for many patients is severe itching or pruritus.
What causes that intense itching?
It's thought to be multifactorial, but high levels of phosphate in the blood, leading to calcium phosphate crystals depositing in the skin, is believed to be a major contributor for many people.
Given this widespread impact and the fact that CKD damage is permanent, treatment becomes about managing everything we've just discussed and eventually replacing kidney function. What are the main strategies?
You can think of it in stages. First is conservative management. This is all about slowing the progression and managing complications. Rigorous blood pressure control is paramount, as is tight blood glucose control in diabetics.
What else falls under conservative management?
Avoiding things that can further harm the kidneys is crucial. So, quitting smoking is huge, as smoking accelerates CKD. Treating urinary tract infections promptly, and very importantly, carefully managing medications, avoiding nephrotoxic drugs whenever possible, and adjusting dosages of other drugs that are cleared by the kidneys.
But eventually, conservative measures aren't enough. When uremia becomes severe or electrolyte problems like hyperkalemia become life-threatening, what's next?
Then you need renal replacement therapy. The main forms are dialysis and transplantation. Let's talk dialysis first. There are two main types.
Okay, what's the first one?
Hemodialysis. This is probably what most people picture. Blood is taken from the body, pumped through an artificial kidney, the dialyzer, which filters out waste products and excess fluid, and then the clean blood is returned to the body.
How does that dialyzer work?
It uses a semi-permeable membrane to separate the blood from a special fluid called dialysate. Waste products move from the blood across the membrane into the dialysate by diffusion, and excess fluid is pulled off by pressure differences.
And this requires special access to the bloodstream.
Yes, you need reliable, high-flow vascular access. The preferred method is creating an arteriovenous, AV fistula, surgically connecting an artery and a vein, usually in the arm. An AV graft, using synthetic material, is another option. These access points are lifelines, but can have complications like clotting, thrombosis, infection, or narrowing.
What are other potential issues with hemodialysis itself?
Hypotension or low blood pressure during the treatment is common. Muscle cramps can occur, and managing fluid balance between treatments can be tricky. Patients typically undergo hemodialysis 3 times a week for several hours each session.
Okay, what's the alternative? Peritoneal dialysis.
Peritoneal dialysis, PD, uses the patient's own peritoneal membrane, the lining of the abdominal cavity, as the dialyzing filter.
How does that work?
A sterile dialysis solution, the dialysate, is infused into the peritoneal cavity through a surgically placed catheter. Waste products and excess fluid from the blood vessels supplying the peritoneum diffuse across the membrane into the dialysate, which sits there for a period called the dwell time and is then drained out and replaced.
And this can be done at home.
Yes, that's a major advantage. There are different schedules. Continuous ambulatory peritoneal dialysis, CAPD, involves several exchanges done manually by the patient throughout the day. Continuous cycler-assisted peritoneal dialysis, CCPD, uses a machine to perform the exchanges automatically overnight while the patient sleeps.
What are the risks with PD?
The most significant risk is peritonitis, an infection of the peritoneal membrane, which can be serious. Because the dialysate contains glucose to help pull off fluid, hyperglycemia can be an issue, especially for diabetic patients. There can also be complications related to the catheter itself.
So dialysis keeps people alive, but the ultimate goal for many is
Kidney transplantation. This is generally considered the treatment of choice for end-stage renal disease, offering the potential for a much better quality of life and freedom from dialysis.
what the big limitation is.
Donor availability.
Yeah.
There's a long waiting list for deceased donor kidneys, although living donation from family members or altruistic donors is also an important option.
And transplantation isn't a cure-all, right? It comes with its own set of challenges.
Definitely. The recipient needs to take powerful immunosuppressive drugs for the rest of their life, medications like cyclosporine, tacrolimus, prednisone, to prevent their immune system from rejecting the transplanted kidney.
And those drugs have side effects.
Yes, they increase the risk of infections, certain types of cancers, and can have other metabolic side effects. So while transplantation is preferred, it requires lifelong medical management and monitoring.
Let's not forget dietary management. That's crucial throughout CKD, isn't it?
Absolutely essential, and it needs to be highly individualized. Generally, it involves restricting protein intake, though high-quality protein is needed, especially for dialysis patients to avoid malnutrition, limiting sodium to help control blood pressure and fluid, and restricting potassium and phosphorus intake as kidney function declines. Fluid intake often needs restriction in later stages too.
Okay, before we wrap up, we should briefly touch on CKD in specific populations, children and older adults. How does it differ in kids?
The causes are often different in children. While diabetes and hypertension are rare causes in kids, the most common culprits are congenital anomalies of the kidney and urinary tract, KK-code, structural problems they're born with.
And the consequences are broader.
Yes, kidney failure in childhood has profound effects beyond just kidney function. It can lead to severe growth impairment, developmental delays, and particularly severe forms of renal osteodystrophy, sometimes with features resembling rickets and increased fracture risk.
So the treatment approach might be different.
Early renal transplantation is often the most favored approach in children and possible to try and optimize growth and development.
What about older adults? We know kidney function naturally declines a bit with age.
That's a key point. The baseline GFR is often lower in older adults, but their serum creatinine level might not reflect this accurately because they tend to have lower muscle mass, and creatinine comes from muscle breakdown.
So their creatinine could look normal even with significantly reduced GFR.
Exactly. It can mask the degree of kidney dysfunction. This, combined with the fact that they often take multiple medications, makes them particularly susceptible to drug-induced kidney injury, those nephrotoxic effects we mentioned earlier.
Does their CKD present differently too?
Sometimes, yes. The clinical presentation might be atypical. For example, symptoms of heart failure might dominate the picture, potentially overshadowing the underlying kidney disease like glomerulonephritis. Diagnosis requires careful consideration of their overall health status.
And treatment decisions. Is age a barrier?
Treatment needs to be highly individualized, considering their comorbidities, functional status, and life expectancy. But age alone shouldn't automatically preclude them from any treatment option, including dialysis or even transplantation in selected healthier older adults. #tagoutro.
Okay, we've covered a huge amount of ground. We've distinguished AKI, the abrupt, often reversible injury categorized by where the problem lies, pre-renal blood flow, interrenal, kidney damage, or postural obstruction.
Right. And we traced the slow, relentless progression of CKD, where permanent damage leads to that cascade of systemic problems, uremia, fluid and electrolyte chaos, devastating bone disease, anemia, and critically, that high risk of cardiovascular complications.
So thinking about the incredible compensatory power of the kidney, hiding disease until 80% is gone, what's the really crucial takeaway message for everyone?
It has to be about early detection and prevention. Because the kidneys hide the damage for so long, identifying and aggressively managing the key risk factors, primarily hypertension and diabetes, is absolutely critical.
And screening for those early signs like albuminuria.
Exactly. Catching that albuminuria, controlling blood pressure, managing blood sugar, these are the most powerful tools we have to slow down the progression towards kidney failure and, just as importantly, reduce the huge burden of associated heart disease that comes with it.
And perhaps a final thought to leave people with, building on what we discussed about older adults and drug risks.
Well, just consider the widespread use of common drugs with known nephrotoxic potential, like NSAIDs, especially in that high-risk elderly population. Their renal reserve is already diminished just by aging.
So even a seemingly harmless medication could potentially tip them into an acute kidney injury.
It absolutely could, potentially with severe and lasting consequences. It really underscores the need for careful medication review and considering kidney function in all patients, but especially the vulnerable ones.
That's a vital point to remember. This has been an incredibly informative deep dive. Thank you for breaking down such a complex topic.
My pleasure. Hopefully it provides a clear framework for understanding kidney failure.
And thank you all for joining us on the deep dive. We hope this exploration helps solidify your understanding of AKI and CKD.